Dr. Rubina Hussain is at another session, so I would like to invite Dr. Sumbul Suhail. Dr. Sumbul Suhail to please take a seat on the dais. Dr. Sumbul, please aa jaiye. Dr. Sumbul Suhail is Professor of Obstetrics and Gynecology, and she is a very senior member of the South Asian Federation of Menopause Societies. The second chair is Dr. Jaideep Malhotra, who's the Managing Director of ART Rainbow IVF. She is Vice President of the Indian Society of Aesthetic and Regenerative Gynecology. She is Chair FIGO Committee of Reproductive Medicine, Endocrinology and Infertility, and immediate past President of SAFOMs. And I would like to invite our third chairperson, who is Dr. Meena Thapa. And Dr. Meena Thapa is from Nepal, but I have not received her CV. So unfortunately, I will not be able to share it with you. I would like to invite Dr. Mananda Ahuja, who is a co-facilitator for this session. My fellow moderator is Professor Mananda Ahuja, and I think she's online. A very good day to Mananda. Mananda is Director Ahuja Healthcare Dental and Infertility Center. She has 40 years of dedicated work for women from adolescence to menopause. She is SAFOM's Vice President since 2018, and she is the President Indian Menopause Society from 2014 and 15. So I invite Professor Maninder Ahuja to take up from here and please introduce the President of SAFOM's, Professor Rohana Hatutova. Do we have Dr. Maninder online? Welcome,
Yeah.
Dr. Maninder.
Thank you, Dr. Rubina Sahel. And Assalamu alaikum to all my friends from Pakistan. And it's nice talking to you, all of you, though I can't see you. And good evening to all our delegates from all over the world and rest of the countries of the SAFOMs. That is Sri Lanka, Nepal, Bangladesh, and of course Pakistan and India. We are the 5 countries who are part of the SAFOMs. And when I was asked by Dr. Rohana Hatotwa, our president, to plan this session, so what I thought was, what is most important aim of all of us in life? What is this? Good practice, money? No, it's the healthy aging which we all wish to have. So towards that direction, even WHO is acting now, and 20 to 2030 30 has been designated as the healthy aging decade for everybody. So even in the menopause societies now we are working on that, and that means that is a prevention of all the chronic diseases, care of the psychosexual problem, psychological problem, and day-to-do hypoestrogenic state which causes and the role of menopause hormone therapy. So we are going to have 4 talks on that, and it's my pleasure to now welcome Dr. Rohana Hatotwa. Can I have his CV, please? Is his CV there, or I'll just introduce him as such because I have known him for a long, long time. A very thorough gentleman and academicians. And he was the founder member of SAFOMs also, along with Dr. Bairam, Dr. Gunaratne, myself, and so many others. And SAFOMs has crossed many landmarks now, and it has grown a lot in stature. Dr. Rohana, are you there? Rubina? Dr. Rohana, CV, I can't see. Is he there? Rubina? Dr. Rubina Sohail? Am I audible or not?
Mananda, there's a technological glitch actually.
Okay.
That is why you have to wait for a minute for
Message
Rohana's
of-
CV.
Okay.
Meanwhile, you
Rohana's-
can introduce Rohana and we will get the CV for you. Just in a minute.
Yeah, so that right, I was talking about SAFOMs and Dr. Rohana Tutwa, as he's one of the founder members. And then I always remember my first visit to Pakistan. That was before we had formed the SAFOMs, and that was I had landed in Karachi. So from coming from India to the land of Pakistan, it was a very real homecoming for me, like that time. And with you people, it's again like a homecoming only. I know there are going to be some technical hitches, but the The first SAFOM's conference was held in India. Then we had in Pakistan itself. Uh, I had the first visit, which we had done as a collaborative meeting of the India and Pakistan, was in 2006. And first we had in
Ready?
Karachi, and then
Okay, Mananda, we are ready with the.
okay. So Dr. Rohana is the founder chairman of the Nine Ways, uh, Nine Wells Care Mother and Secretary General of Asia. I lost. I can see. He's the Secretary General of Asia Oceania Federation of Obstetrics and Gynecology, immediate past chairman of Menstrual Disorders Committee of FIGO, President South Asian Federation of Obstetrics and Gynecology, and President South Asian Federation of Menopause Societies, President World Justice Organization, and past President Sri Lanka College of Obstetrics and Gynecology, past President Menopause Society of Sri Lanka, and Treasurer Asia Pacific Society for Infections in Gynecology and Obstetrics. Dr. Rohana, it's a really proud privilege to welcome you on this SAFOM session in the SOPOG and 18th International Biennial Conference. Do we have his address ready? Okay, anyway, we'll be talking about South Asian Federation of Menopause Societies. What they are doing is basically the South Asian countries, they have the same very common features as far as the menopause experience is concerned. So that's why we started this forms organization. So which is we are not only discussing the same things, what are our problems in managing the menopausal women or the midlife onwards women. Prevention is one of the main factors, but then comes the other factors which are available because of the socio-cultural issues of these countries. So somewhere along the line, menopause is accepted as a normal phenomena, but there are sometimes issues where the women are not able to cope up with the problems of menopause, because basically it's fact that it's in a hypoestrogenic state. So the problems can be there on the all the systems of the body where the estrogen receptors are present. So we are looking into that. We are doing research on those issues. We are finding the social cultural differences and how we can over them, and how we can give a comfortable life to these women, and how can we prevent the various non-communicable diseases which are increased during this age group, and especially being the osteoporosis, then psychosexual problems of genitourinary syndrome, which are very important. Dr. Rubina, we are not able to welcome Dr. Rohana.
Professor Halima Yasmin, Secretary General of the Society, and all the office bearers for giving support and opportunity to have a session in this wonderful Congress. I also like to thank Professor Rubina Sohel, who is the chair in the PIGO Committee on Women Facing Crisis, for joining with support in conducting this session. And I thank all the PIGO officers for approving this program. And then Professor Rubina Sohel, and she is the past president of SAFOG and a very active member in SAFOG activities, and Professor Yusuf Latif, who is the Secretary General, really organized and planned this program and did all the organizations. So I thank them for all their work. Firstly, I would like to make a brief introduction to SAFOG, but I know in Pakistan I don't have to do it, because it is in Pakistan that the real foundation, the solid foundation, was laid to SAFOG 25 years ago. The first meeting to form SAFOG was held in Sri Lanka, but the first conference was held under the leadership of Professor Rashid Latif Khan in Pakistan, and it was wonderfully organized by Professor Farooq Saman and be assisted by Professor Rubina Sohel. It was a very successful conference, and that gave the real impetus to for the SAFOM to move forward. And since then, we have had conferences every 2 years, rotating through with among our member countries, which are Bangladesh, India, Nepal, Pakistan, Sri Lanka, and also Afghanistan. Also, though they are not full members, we are working closely with Bhutan and Maldives. So actually, SAFOM is a very friendly family where we work together as a very closely knit family, and we conduct so many educational activities with in our region. And now SAFOM is well recognized by the international organizations. Uh, so I I like to conclude this introduction by inviting all of you for this SAFOP conference, which will be, that is the Silver Jubilee Conference, which will be held in Sri Lanka in September this year. Now, for this session, uh, it's a very well chosen session on violence against healthcare professionals. Actually, this is a topic which is not very much spoken about, but it is something which we have to speak because the violence against healthcare workers is gradually increasing, and it is becoming a real issue among healthcare personnel. So I thank the organizers for choosing this topic, and to discuss this topic, we have real experts who have done so much of work.
So the session is going to run like this: that we have a panel discussion, which is case-based discussion with four main focus areas of vasomotor symptoms, of genitourinary syndrome, of menopause, of mental health, and musculoskeletal health. So I will start with my own presentation first, and the topic of my presentation is vasomotor symptoms, and I would request the organizers to please put up my PowerPoint presentation. So it's actually a simple strategy that we have tried to put in clinical scenarios, and we are going to discuss them so that the topic is of interest to you. The topic that was allocated to me was vasomotor symptoms. Next, please. Just to bring to you things in proper perspective, you understand that vasomotor symptoms sometimes may start early and as early as 42 or 45 years of age, and they can persist beyond 60 years of age. So, vasomotor symptoms are of extreme importance. Next slide, please. The second fact that I want to highlight to you is that lifestyle modification in terms of a healthy diet and in terms of exercise is very important for menopausal women. And this change should start at 35 years of age, where women should realize that they are going to approach menopause and they need to be prepared for it. Next, please. So, the one and only scenario that I'm going to discuss with you next, please, is that of a lady. Her name was Mrs. Sumera Farman. She was 33 years of age, married for 5 years, para 2 plus 0, who presented with absent menstruation for the last 1 year. Remember, she was 33 with no periods for the last 1 year. She suffered from hot flashes, sweating, and find it difficult to sleep. On investigation, her FSH was 45 milli international units per ml, and she repeated the FSH and serum estradiol after 6 weeks, according to the doctor's advice. And she was very concerned about the symptoms and wanted to know what could be done for the resumption of menstruation. Next, please. Now, the first thing is that the diagnosis in this lady was premature ovarian insufficiency because she was 33, her FSH level was 45 on more than two occasions, 6 weeks apart, and a low estradiol level. That is why the diagnosis of POI was made. So the question is that this is a lady presenting to you with POI. What will be the governing principles for providing her hormone replacement therapy? And all of us know that the answer for her is simple but difficult, that she needs hormone replacement therapy till the natural age of menopause. And hormone replacement therapy is the most effective therapy for the vasomotor symptoms that she is likely to encounter. It has the added advantage that it is going to take care of the genitourinary symptoms, because you know that girls as young as 33, they are sexually active and they have a long time to go. So they need to be protected in terms of genitourinary system. The joint and muscle pains, the mood swings, and sleep disturbances all can be protected and prevented to some extent by providing hormonal therapy. Hormonal therapy also preserves the bone density, it improves the quality of life and the sexual function. But before we are going to prescribe hormone replacement therapy, you know, it is there are hovering myths and misconceptions around hormone replacement therapy. Therefore, it is important that we make an accurate evaluation of the woman before we put her on hormone replacement therapy. For that, a complete evaluation is required, including investigation in terms of mammogram. At 33, probably we would not like to do a mammogram, but a ultrasound, lipid profile, and other investigations. HRT in these women should be taken until the natural age of menopause, which for South Asia on an average is around 51 years of age. And women with hormone replacement therapy should have an annual consultation. Now, this slide, the next one which I'm sharing with you, it actually, next please, it actually shares with you whether we want to give her continuous estrogen or we want to give her sequential hormone replacement therapy or continuous combined hormone replacement therapy. And the simple answer is actually on the left side of the screen. So if the lady did not have a uterus, she was a candidate for continuous estrogen. But because she has a uterus, she's para 2 plus 0, nothing has been done to the uterus as yet other than the premature menopause. She is actually, वापस जाइएगा please. She is actually a candidate for either continuous sequential hormone replacement therapy, which is a combination of estrogen and progesterone, but the tablets are given without a break so that she continues to take the medication without any intervening periods. Or more commonly, it is given as a combined hormone replacement therapy in which there is going to be regular bleeding at the end of the cycle. So if you looked at the same patient now, next slide please, Mrs. Sumaira Farman, with a diagnosis, next please, with a diagnosis of POI, uterus is intact. What are you going to do with her? You are going to counsel her. You are going to talk about lifestyle modification in terms of diet and exercise. Hormone therapy is important, but some non-hormonal therapies might help as well, especially SSRIs, venlafaxine can be used too. The woman needs to be kept under follow-up, and hormone replacement therapy has to be given till the natural age of menopause. I think I will stop over here and just one more slide if time allows. एक और दिखाते हैं please. This is just the decision making tool. Basically, we are trying to decide what kind of hormone replacement therapy do we want to give these women who are suffering from vasomotor symptoms and the uterus is intact. So there are four choices: Tibolone, Clymin, Venlafaxine. Premarin can only be given if there is no uterus or in combination with medroxyprogesterone. So Tibolone actually helps by preventing osteoporosis, estrogen deficiency, and in the intact uterus, limited by its side effect of thromboembolism and liver disease. Clymin can cause a bit of breast pain, but it is a good product for POI, especially with urogenital atrophy, osteoporosis, depression, and vasomotor symptoms. Venlafaxine comes with the brand name of Effexor in Pakistan. It is a SSRI, and it is basically given to relieve vasomotor symptoms in those patients who are not good candidates for hormone replacement therapy. But it can cause drowsiness, it can cause some dizziness, and in some patients, it takes some time getting used to the product. So if a patient comes to you back in a couple of days and says that they are having problems with venlafaxine, tell them to wait for a while, start with the lowest possible dose and then build it up. With this, I think I would like to thank you all and complete my talk over here. If there are any questions, I'll be happy to answer. I totally agree with you. There's a lot of evidence to support that is a good combination to use, and this has got lesser chances of effects on the breast. So I agree with you. Actually, medroxyprogesterone was a slip of the tongue, and you caught it well. So you were listening to what I was saying. But if a patient does not find hormone replacement therapy suitable for her, as I said, venlafaxine is a very good choice, and I'm using it in my patients who are either anxious because of hormone replacement therapy or in whom it is contraindicated. So, thank you very much. Please.
A woman above 45 or 48 years of age, still having regular periods but experiencing intractable hot flushes. So what treatment then we can propose?
So that's a very good question. Thank you very much. And this is also a very challenging question because women who have not yet achieved menopause and are suffering from symptoms, we find it difficult to handle these women. But Climate is a good product for them. It can be given to those patients who are still having their periods. And again, venlafaxine can be given to them if they're still having their periods. But you have to be monitoring them very carefully because sometimes it becomes very difficult to look at the side effects and understand what is happening because of what.
And may I have another small
Yes,
question?
please.
When to decide if she's a candidate for a sequential combined HRT or a continuous combined HRT?
It actually depends on the choice of the woman. It does not depend on us actually. It depends on the choice, how we counsel her, and what does she like. Some women do not want to have periods later on. So there are others who would say that they feel better if they menstruate every month. So it depends on their choice. With this, I would like to welcome Professor Rubina Hussain to the session. Dr. Rubina, thank you very much for joining us. And we are so glad that you could make it over here. There's a little bit of change in program and because of certain logistical issues, and one of our foreign speakers is online, and with apology to the rest of the speakers and according to the advice of the chairs and Professor Batul, I am requesting Dr. Hogne Wick, who's a Chief Medical Officer, to be talking about bone health, a role of vitamin K. If you could connect him, please. And I'm very sorry to the audience who will have to wait for the rest of the very important session of SAFOMs because the scenarios are made with a lot of passion and interesting debate can be coming out of it. So please don't go and let's listen to this talk. Thank you very much.
So normally it's happened that if you lose bone and bone calcium, you will also experience age-related hardening of the arteries. This negative development can be reversed by using vitamin K2, because this is something that happens because of lack of vitamin K2. So this slide, we see that bone is a key area where vitamin K2 together with D3, vitamin D3, calcium, secures bone. And for the cardiovascular health, we secure that we do not have aggregation of calcium and develops arteries, have enough vitamin K2. Can we have the next slide, please? Yes. So here we see that vitamin K is not the same thing. Vitamin K1 is located in the liver. Can we get one back, please? One, please. Can we get one slide back, please? Yeah. So if we have the problem, it is important to say that vitamin A1 is important for the coagulation system, and vitamin K2 is important for calcium location in the body. So therefore, vitamin K2 is important to place calcium in the right place. And this slide tells us something about, here it's going all too fast. Sorry about that. Can we please go back a little? Can we please go back a little? Please reverse. Yes. So this slide tells us, this tells us that we need to put calcium in the right place. And the next slide, please. Can I see it? The next slide. And this slide tells us that the importance of the mechanisms here of activation of osteocalcin is inhibition of the osteoclasts that are taking down the density of bone. It's also important for the improvement of the collagen accumulation, is binding calcium together in the bone matrix. So, and here we can see a little why we need K2, because most people are deficient in vitamin K2. And this is shown for 97% of the population are vitamin K2. That is why it needs to add K2. This to show you that the bone mass index is reduced when you come to a certain age, and that is why vitamin K2 helps you to remain the bone strength when it normally is reduced if you have sufficient amount of vitamin K2 activating the osteocalcin. So the next slide, please. So the next slide. The next slide shows that in the diet, it's only fermented food found in the natural food that we use in Japan, some other fermented support food that can give us sufficient amount of K2. Here we see the picture of some of the most important international publications that have made the scientific evidence for the importance of vitamin K2. And by using vitamin K2, we are then able to inhibit processes where we see the age-related loss of bone strength that can develop later on osteoporosis. In this slide, we see some kind of pictures showing where we have carboxylated osteocalcin. Uncarboxylated osteocalcin is an indicator this developing osteoporosis during age, and we see this uncarboxylated dephosphorylated osteocalcin is higher in the postmenopausal age than premenopausal, and it's been the highest value measured in people in elderly women. So this is to show you that we need something to activate osteocalcin. Here, this slide is showing you that we need around 180 micrograms of vitamin K2. Then it comes to the steady state level, have sufficient amount of vitamin K2 in body. Yes, and then we can move to the next slide. And again, see that the scientific evidence that vitamin K2 came from a 3-year clinical trial where we compared the placebo group of women with the group getting 180 microgram vitamin K2 every day for 3 years. And then we were able to document the health benefits of vitamin K2. The next slide, please. This shows the activation of calcium and of matrix GLA protein that is done by vitamin K2 and will then give you possibilities to have healthy arteries, strong bone for a long time, much longer than with K2. The next slide, please. And therefore, slide really tells you that the combination of calcium and vitamin D needs K2 to secure bone mineral density. We have talked about that calcium is the building stone in the bone, but that you need vitamin D to produce sufficient amounts of osteocalcin. But again, that osteocalcin need to be activated by vitamin K2. And that is why the K2 is so important for strong bone. And on the same side, vitamin K2 will activate matrix GLA protein, securing that we do not develop stiff arterial walls that will rise to cardiovascular diseases. So the next slide, please. This slide says something about other effects of vitamin K2 that is beyond the cardiovascular part and beyond the bone part, saying us that vitamin K2 is also demonstrated in some early studies to be important for all vitamin K dependent protein. It is important for the aging processes in a lot of tissues. It's important to inhibit stress and oxidative stress in the body. It has also anti-inflammatory effects, and it has effect on the hormone system. I understand it's a problem with the connection with Karachi, but the main message is that we need vitamin K2 from early age to the old age. That is an important vitamin for especially the bone. Okay, I apologize for that connection. Wish you all the best and that you use K2 and take advantage of that.
I would like to introduce to you Dr. Zeenat Nasreen, who's a representative from Bangladesh, and Dr. Zeenat Nasreen is going to talk about the genitourinary syndrome. So I would request our facilitators from Orbit to please put up the talk of Dr. Zeenat Nasreen.
My topic of presentation is genitourinary syndrome of menopause. GSM, or genitourinary syndrome of menopause, actually the vaginal health is an essential component of active and healthy aging in women at menopause and beyond. And this GSM affects from 27 to 84% of postmenopausal women, which comprises a lot of problems like dryness, burning, itching, irritation of the vagina, sexual symptoms like dyspareunia and reduced sexual function, and urinary symptoms like dysuria, frequency, urgency, and recurrent UTI. Several international surveys have extensively documented the need to improve GSM management because of its strong impact on women's daily life, quality life, and the couple's intimacy. Urogenital aging is a very ancient problem, but is newly recognized by assessing risk factors. Timely diagnosis and intervention can prevent the progression of this disease. Revive survey conducted showed that the onset of GSM has already been reported in the majority of the women within the perimenopause and early postmenopause. But unfortunately, women are oblivious to share this issue. So healthcare providers need to be proactive in the early recognition of GSM in order to preserve urogenital and sexual longevity. What are the risk factors of GMS? How can we know the risks? Well, there are lots of risk factors like cigarette smoking, nephrectomy, Sjogren's syndrome, radiotherapy, infection, drugs, breast cancer, and mostly the menopause, because all of you know that estrogen receptors are abundant in the vagina, vestibule, and vulva, and withdrawal of estrogen during menopause produces this GSM. What is the key to diagnose? Well, in general, GSM is typically a clinical diagnosis, and very few laboratory tests are needed. It's just to support the evidence or to look at the efficacy of the drugs, like vaginal pH and vaginal maturation index. Objective diagnosis is confirmed by accurate pelvic examination, which actually do, and which can be rated on validated scales. The vaginal health index is another clinical tool by evaluating 5 parameters like vaginal elasticity, secretions, pH, its epithelial mucous membrane, and hydration. That allows to obtain a final score, and the score varies from 5 to 25. The lower the score, and severity of the genital atrophy. And this is actually the vaginal objective and subjective table for the vaginal atrophy. And this is a simple toolkit to diagnose. What's the treatment then? The chronic nature of genitourinary syndrome for menopause indicate that the treatment should preferably started as soon as the symptom starts. For moderate and severe condition, the first line treatment is the local estrogen hormone therapy, either alone or in combination with systemic HRT. With the local estrogen therapy, the systemic estrogen absorption is very minimum, and that also permits to use this for the women who are suffering from breast cancer. But definitely we need to discuss with the oncologists. Local androgen, such as DHEA, fisheries, and testosterone cream are very new promising options. The other important option, which is also approved, is the Ospimifen. That is a serum that is third generation of the selective estrogen receptor modulator, and that can be used orally, and it improves the vaginal dryness as well as improve the sexuality. The mild symptoms, sign symptoms, the vaginal moisturizer and lubricants and the maintenance of the sexual activity are very important. However, lubricants are short-acting and are useful to reduce the friction during sex, whereas moisturizers are longer-acting and they stay longer in the vagina, and they may exert a trophic effect in the vaginal wall. Pelvic floor muscle training is important for women who are suffering from urinary incontinence. And microablative fractional carbon dioxide laser, Abraham laser, energy-based devices are increasing with huge popularity, and the safety data is quite good. So I want to conclude here by saying that Wisdom Survey outlined that the comfort level of healthcare providers when prescribing VVA treatment or GSM treatment is still suboptimal. So definitely they need to have a wide knowledge to address the GSM. Recent studies pointed to the importance of addressing GSM as potentially early marker of the poor general health in analogy with vasomotor symptoms. Therefore, a standard GSM care in elderly women is desirable to enhance the physical, emotional, and mental well-being. Early recognition of the signs and symptoms of GSM, individual counseling, and personalized treatment strategies are the key step in helping women to maintain the quality of their life. Thank you very much for kind attention.
Thank you very much, Dr. Zinat Nasreen, for your wonderful presentation. The important point highlighted by Dr. Zinat was the fact that women present to us with symptoms of vulvovaginal atrophy and we don't know what to do. So in your clinics, you will be finding women, elderly women, coming to you with repeated urinary tract infections, with burning in the vagina, and they have been taking mostly treatment from urologists and sometimes gynecologists too, and the solution is not available. So Dr. Nasreen basically outlined for you the treatment options, some of which are available in Pakistan and some of which are not available in Pakistan. Giving hormonal replacement therapy, providing local Premarin is a solution, but obviously you have to be careful because the Premarin dose, if it is not controlled properly, it will result in postmenopausal bleeding, which will make you and the patient anxious. Just want to share with you that the use of laser is the new thing for improvement of urogenital atrophy. और अभी मैं किसी से बात कर रही थी तो the doctor who's doing laser in Lahore, she informed me that they are doing 3 sittings to patients, and what laser does to the local area is that it improves by the heat, it improves the circulation in the vulvovaginal tissues, and by improving the circulation, healing takes place and the vagina becomes somewhat moist and lubricated. So I don't know how long do these effects last, but this is a treatment choice which is also available. So thank you very much, Dr. Zeenat Nasreen. Our next speaker is Professor Piyusha Milani Atapattu, and she is basically professor in physiology and specialist physician, Faculty of Medicine, University of Colombo. She is President, Physiological Society of Sri Lanka, President-elect of Menopause Society of Sri Lanka, Deputy Secretary General of SAFOMs, and Vice President of the South Asian Association of Physiologists. Dr. Atapattu is going to speak upon the topic of mental health. So, Dr. Atapattu, it is over to you. And the Orbit team, please, Dr. Atapattu की presentation जो है वो लगा दीजिए. Mental health in aging women is again a very, very important topic. And I think as gynecologists, we need to be aware of it, how to help these women, what are the choices available, and what can we do. Let's see what she has to tell us.
Ladies and gentlemen, organizations of the SOGP conference for inviting me to contribute to the SAFOM session. I will broadly address the mental health issues of women in midlife and beyond in the next few minutes. When you Google menopause and mental health, this is what you see. You will see many sad women, the pictures of many sad women, which makes us perceive menopause as being associated with a negative mental health. Well, there are mood changes associated with menopause, such as irritability, sadness, lack of motivation, anxiety, and depression. Insomnia aggravates the above, and many women experience difficulty in concentrating and memory disturbances. These effects can cause emotional strain. So why is mental health affected in menopause? Menopause is an important life transition phase with increased vulnerability in well-being. Reproductive aging affects psychological functioning as well as well-being in women. Hormonal changes begin several years before menopause, and there's a rapid decline in estrogen within 6 months around menopause. Midlife has traditionally been considered to induce psychological stress due to many physical and psychosocial problems. So what contributes to psychological issues around menopause? The changes in hormonal milieu, especially low estrogen, contributes not only to physical symptoms, but to psychological problems. High FSH and LH are linked to stress associated with menopause. Physical symptoms such as hot flushes and night sweats might contribute to insomnia. Fatigue, joint pains, and stress incontinence may prevent a woman from doing the normal activities, and stress incontinence may be an embarrassment causing further stress. The change in physical appearance, especially gaining weight, thinning hair, and aging skin, might weigh upon a woman's mind, and reaching the end of reproductive life may be a problem, especially to women of younger age who have not completed their families. All these contribute to changes in relationships, especially with the spouse and the rest of the family. Many women lack knowledge on menopause and they fear the symptoms, thinking that they are getting some serious illness. And furthermore, they may be diagnosed with new NCDs around this time. Children leaving home and becoming independent may lead to emptiness syndrome, and women feel birthless, especially if they're unemployed. Moreover, social stigma of menopause make women suffer in silence. So what can be done to boost mental health? Mental well-being is associated with better long-term health outcomes and survival in women. And women should be made aware that menopause is a normal phase of life, and the symptoms of menopause have ways of being managed. Simple lifestyle measures such as healthy diet, regular exercise, and stopping smoking are beneficial to mental health as well as physical problems. And regular exercise especially improve mood, cognition, and concentration, and is overall beneficial to mental health. Brain needs to be exercised as well as the body, and embarking on new learning, reading, and memory games will help in exercising the brain. Increasing social interactions is very important for improving cognition as well as giving happiness. When there is suboptimal response to the above, women should be referred to specialized management. Professional counseling per se may help many women, and psychological evaluation will help in getting an underlying diagnosis. Depression is managed by antidepressants and psychological therapy. Relaxation techniques help in anxiety. Sleep hygiene is improved, it will improve insomnia, and medication will obviously help these conditions. Evaluation of management of dementia is important, especially if there is significant memory impairment. Menopausal hormone therapy is not directly beneficial, but may be useful secondary to improving physical symptoms. So actually, is there negative mental health in menopause? Menopause literature mostly focuses on negative aspects, but some cross-sectional studies have shown that there is no relationship between menopausal state and mental well-being. And more recent studies have shown that midlife may be a rather satisfying stage of life with a high level of mental well-being, especially in Asian women. Thus, both negative and also positive dimensions of mental health are experienced in menopause. Well, there are plus points of menopause. Women are now free from many responsibilities burdening younger women. There is no menstruation or pregnancy inconveniencing them. Women are still young and healthy and able to enjoy life. And furthermore, they are financially stable, capable, respected, powerful, and at the tops of their professions. So, emphasizing on positive mental health while identifying and managing negative mental health issues will ensure a healthy and happy menopause for women. Thank you.
Thank you very much, Dr. Atapatu, to finishing well in time. तालियां बजाने में कोई हद नहीं है, बहुत खुश होंगे. Thank you very much. Dr. Atapatu has raised a very important point of talking about mood swings which might happen in menopause, and the mood swings are happening because of a low estrogen level. So vasomotor hormone replacement therapy may be a good option, but so is exercise, a good diet, plenty of sleep, having positive energy, cognitive behavior therapy, keeping in the company of good people, and sometimes when things get really bad, then you might seek professional help. So thank you very much, Dr. Atapatu. Our next speaker is none other than Dr. Mananda Ahuja, who's a great friend of mine, and I am inspired whenever I look at my weight and then I look at her weight and her body image, I get inspired from her. And Dr. Mananda is really an example of a self-example of how to take yourself through menopause. She does yoga, she exercises, she dances, and whatnot. And she herself, she cycles, and she has labeled herself a thought-provoking leader, and I agree with her. So without further ado, I am inviting Dr. Mananda Ahuja, and she has very rightly and very aptly selected for herself the topic of musculoskeletal health. So Dr. Mananda Ahuja ki presentation laga de. And I'm sure she is there at the end of the session, and maybe she would like to answer a couple of questions for you.
Of 18th Biennial International Conference being held in a hybrid way in Karachi. And I'm talking from the platform of SAFOMs, as Vice President of SAFOMs, Dr. Mananda Ahuja from India. My topic for today is musculoskeletal health risk assessment and management. This topic is of utmost importance because of the global aging of the populations, and osteoporosis, sarcopenia, and fragility are three factors which are robbing the people of their independence and giving them morbidities and mortalities because of the high incidence of fractures. And this is because of the low bone mass density, which can be there because of the muscle bone mass density, because of the sarcopenia can also be there, and also because of the osteoporosis. So it has a large impact on the healthcare budget, public healthcare budget. So we have to find some clinical methods, clinical tools where we can early diagnose these conditions and prevent them, to give a better life to the aging population of the world. So the first thing which we can do is assess the risk factors, because the low bone mass density is the first reason for the osteoporosis. And low bone determinants of the low bone mass density are menopause, aging, calcium, vitamin D, alcohol intake, smoking, other dietary factor, physical activity, and chronic diseases. And how this low bone mass density is assessed is by the DEXA scan. Now, DEXA scan will classify these women into normal bone density, osteopenia from -2 to -2.5, or osteoporosis beyond that. But we don't treat bone mass density, BMD. We treat when there is increased risk of fractures is there, because mortality and morbidity is because of the increased risk of fractures. So though we are advised to start the DEXA scan at 65 years of age for the NOF and Indian Menopause Society earlier, and if there are risk factors, then we can do earlier also. But the problem is that these machines of DEXA machines are not available all over, especially in MICs and LIC countries, and they cannot reach out to the populations at each and every angle of the country. So we have to have some other risk calculating tools available with us. FREX is one of these tools where we can use BMD or without BMD also, and this will predict the 10 years risk factor for the hip fracture or for other fractures. So if the fracture risk is more than 20% for major fractures and more than 3% for the hip fractures, then we start the treatment. So what are the risk factors which are taken by these format or prior fragility fractures? Familial history, glucocorticoid, current smoking, high alcohol intake, rheumatoid arthritis. These are the risk factors which are being covered by the FREX format, but it does not cover about falls in the previous months, or in nutrition, or gait, balance, or physical activity amount. So even at the lower levels, when we have these risks, so even when the fracture is probability is less than 20, we can start the treatment if other risk factors are present. Then we need on our desk, because it's an online tool, so internet connectivity may not be there available at all the time. So then we have to have some assessment tools on our desk itself, and Austral osteoporosis self-assessment tool is that tool for the Asians, where fracture risk assessment can be done with the help of just weight and age plotted at in this chart, and you can assess whether the risk is high, medium, or low. If it is high or medium, then we can advise either DEXA scan or we can directly start the treatment. And if it's low, then triaging is done, because in those populations we don't have to do DEXA scan. Then clinical risk factors are there. When the patient enters your consultation room, you should have a high suspicion of diagnosing osteoporosis. So fractures of the vertebrae, compression fractures of the vertebrae can be diagnosed if you look at the height. It's 2 centimeters less than previous year. Occiput wall distance is more than 4 centimeters, or you cannot insinuate 3 fingers between the iliac crust and the ribs, that means patient has had vertebral fractures and you should put them on treatment. Other risk factor is if there is a loss of weight. Then we come to the assessment of the muscle mass, strength, and physical performance. Because this is what is going to tell you about the risk of fall of these patients. So it's not the osteoporosis which is killing these patients, it's the fractures which is killing these patients. So we have to avoid those fractures. And if the muscle mass is low, which is can be assessed by DEXA, MRI, BIS, CT, or creatinine clearance, or muscle strength or physical performance, which can be checked in the clinic itself by simple tests like standing from the chair, sitting down, walking down 0.8 meters per second, or time up and go 3 meters. If it's more than 12 seconds, then these patients have more risk of falling. And very simple SARCF score. If it is more than 4, that means the patients, they need future help in maintaining their bone mass by increasing their muscle strength and giving them balance exercises and other treatments. So then we can refer them to the other specialists also. So what they test is simple strength assistance in walking, rising from a chair, climbing chairs and falls, and anybody can do it online even. So once we have known that the patient is at high risk of fractures from the FRAC score, from the risk factors, or from the Austral screen tool, or clinical assessment, or from the physical parameters, then what we have to do is start the lifestyle modifications. First, in all the patients, you have to advise exercise, vitamin D, calcium wherever needed, low caffeine, low salt, and prevention of falls is very, very important. So you have to tell them about the exercises. Treatment is, of course, available in the form of anti-disruptive drugs, anabolic drugs, and menopause hormone therapy can also be given. But it's a long chronic process. The disease so needs adherence. That is very important. Bone turnover markers can be used in the urine or serum for knowing the compliance and the effect of the medicines. Artificial intelligence, COVID has taught us how to reach out to the masses in the distant areas also. And with the same way, we can go with the proper message when to do self-assessment, what are the risk factors, and how they should be doing exercises and diet and nutrition also. So sum up, it's a preventable disease. It can be prevented, and to diagnose osteoporosis, think osteoporosis, so that we can decrease the mortality, morbidity, and dependence of these people on the public health expenditure, and they can be made independent. Thank you very much for the kind hearing. Thank you very much.
I felt very highly privileged, chairing this session. And I think it's really very important for all of us to understand today that as time is passing by and as, we are studying MHT and menopause in much better way, today we are discovering that, yes, quality of life in this age group in which we actually lead 1/3 of our lifetime is really very important. And today, MHT is actually playing a much greater role where the benefits are definitely outweighing the risks, especially in well-selected patients. And this is something which we should be definitely looking at, because as we today understand from these 2 lectures by Dr. Mananda Ahuja and Piyusha, that MHT is increasing the type 1 collagen production, and what we have understood is that it maintains a great equilibrium between the bone resorption and formation by modulating the osteoblasts and the osteoclastic activities by the T cell regulation. What is also more important is that it affects the structure of the musculoskeletal system, the muscles, the tendons, and the ligaments. So what we are really prone to during this period to injury is something that can also, along with MHT and lifestyle modification, can really promote health and optimize our performance and quality of life. Now, the shifts of these hormones in this age group can also cause a lot of temporary and maybe long-term changes in our neurocognition, in our mood swings, memory losses, and an overall decrease in the mental health and leading to depression and many other mental problems later on. And what was seen is that MHT does help to actually reduce or maybe restore some of it in the times to come. And another very important aspect that we have very recent studies which have come up, that in a community of postmenopausal schizophrenic women, now what was seen was that ones who were on MHT actually had much lesser negative symptoms than the ones who were not on MHT. So every day one is discovering, newer and uses and benefits of MHT. And there have been multiple studies which have shown that MHT may prevent depression, may increase or improve the sleep quality. And all these associations can definitely lead to a lot of psychological well-being and mental health along with the use of MHT in this age group. So I really, really am overwhelmed by the presentations, and I thank the speakers for a great job. And I thank the SOGP for giving me this opportunity to share this wonderful session. Thank you very much.
Thank you very much for talking about the opportunities and challenges in midlife.